I'm delighted to be here today. I'm always delighted to come back to Ireland. My claim to fame is that I'm probably wanted by your local police. I tipped over a car once near Shannon Airport. And after we kind of looked at it for a while, I suggested to the lorry drivers that they put it back on its wheels, and I drove away and never did tell the hire car company that I'd done that. So I always come here with a little bit of fear. I've also never driven here since then, which is probably a good thing. Let's see where we are today. There we go. My slides are not nearly as pretty. Sorry. I want to talk a little about how we go about maximizing healthcare. We've heard about the costs of chronic disease. We've heard about the benefits of self-management. A lot of what I have to say has already been said. But I think if we're really going to maximize healthcare today, that what we need activated patients. We actually need to change the practice of how healthcare is given. And that's another lecture for another day. If anybody wants to talk about that, we can. I'm not going to talk about it today, except to say that practice change is possible and is beneficial to patients. We also have to change physicians and other health professionals' beliefs about self-management. Very nice study done by a colleague of mine looked at health professional beliefs in both the UK and in the United States. And what they found was that they really believed that patients should adhere to their medications, but they really shouldn't seek knowledge. It was very interesting. Just do what I say, and that's enough. And so that if we want to really maximize healthcare and minimize healthcare expenses, what we have to do is we have to change both patients and healthcare practice. Today, I'm going to be just talking about changing behaviors and attitudes of people with chronic conditions. So this was a study. I'm giving you the titles of these studies. You can look them up if you want. You can also there's summaries of them on our website. But this is a very old study. This is actually the study that Grania referred to earlier today. What happened was that I was going off to Australia for a month. This is the truth about science, folks. I was going off to Australia for a month, and I had a research assistant that needed something to do. So I said, here's a list of patients that we were in our programs, a group of people who were in our programs 4 years ago. See if you can find them and get them to fill out questionnaires for us. And she did, which was quite surprising. This is kind of what they looked like. And this is what we found out. 4 years later, we'd never seen these people before again. They had less pain. Their disability had increased a little bit, and I'm going to talk about that in a moment. And their visits to physicians had decreased. We actually did not believe this data. It was too good. So we did the whole study again with another group of people, and we got the same results. Now, how about this worrisome piece that the disability increased? Well, it didn't increase very much. And thankfully, I had some colleagues that were doing a longitudinal study, and it looks like without the program, it probably would have increased by about 10 to 12%. So the disability was increasing about as we'd expect, or maybe a little bit less. So then we became less concerned about the disability. As I said, we did the same thing again, got the same results. This is, by the way, the longest study we have ever done is 4 years out. We've never been able to repeat that for a variety of reasons. But I think this is very interesting. I'm not sure what those results would look like today because these results were done before the era of biologics. In these days, we were just beginning to use methotrexate. But again, most of these people didn't have RA, so it probably isn't that relevant because the care for osteoarthritis has not changed a great deal in the last 30 years. So this is a study that we've done more recently. We wanted to find out what would happen if we moved the arthritis self-management course onto the internet. Now, our internet programs, I'm not sure I can show it to you now. This was 700 people. And they were randomized to either take the program or to take the program later, and data were collected at baseline in 12 months. Before I show you this one, I'm going to tell you a little bit about the Internet program. I thought I had some slides there, but I don't. Internet program is interesting because it has 3 pieces to it. It has the Learning Center, and the Learning Center is all the things you need to know about arthritis. They're all the things that we teach in the regular self-management program. And somebody earlier today said, well, yeah, but how about action planning and all this sort of thing where people are actually talking to each other? The real core of our Internet program is the discussion center. On the discussion center, people talk to each other because these people there's usually 20 to 25 people. The course is 6 weeks. They can log on whenever they want. They don't have to log on all together. But each week they'll post an action plan, each week they'll put a problem, and then they can go back on and see what other people have written to them about possible solutions or things they'd want to do. Strangely enough, we have more discussion and deeper discussion online than we have in small group. The nice thing about online is that very often you don't know what color people are, you don't know whether they're fat or thin, you don't know their status in life, you don't know their age, and sometimes you don't even know their gender. And so it's a very great leveler. At this point in the United States, our Arthritis Foundation in the United States is doing only a tiny bit with small group programs, but they are sponsoring online nationally. And so let's see what we found out about online at 12 months. The data were pretty much the same as for the small group. People had less pain, less disability, less health distress. They were doing more of the things they wanted to do in life, whether that's teaching school or cooking or booting the devil to the boot, whatever it is. And they were reporting better self-reported health. And you might wonder, why do we keep seeing this thing called self-reported health? Who cares? Well, the reason we care is because this is the best proxy we have for future health. It's not cholesterol, it's not smoking, it's not A1C, it's not joint count. If you ask somebody, how healthy are you going from excellent to poor, their answer is a very good indication of what their future health is going to be. And that's why we're interested in this particular variable. It's a question that originally came out of the Canadian National Healthcare System. It's now part of the questionnaires in the US National Health Survey. I don't know how it's being used in Ireland. Does anybody know if that question is being used nationally here? No, okay. Anyway, good question. So then we say, so are these improvements important? And because, you can do anything you want with statistics. And who cares about 8% anyway? Well, at 12 months, 76% of the participants had what is called a moderate effect size in science. And if you get a moderate effect size in science, it's a pretty big deal. And 76% of these people had gotten a moderate effect size in at least one outcome. Because not everybody changes in the same way. And 24% of them had changes in 3 or more outcomes. Now I'm going to show you, I'm going to move to a whole nother realm, but before I do that, have to talk to you a little bit about what happened next. After we had been doing arthritis programs for about 12, 14 years, people with arthritis were saying to us, this is a great course, but you're telling me one thing and my cardiologist is telling me something else. Or this is a great course, but I also have COPD and I don't know how to deal with those two things together. Or this is a great course, but I also have diabetes. And we started looking at the national figures in the United States. And as it turns out, most of the people above the age of 50 in the United States have 2 or more chronic conditions. And my guess is that's true here in Ireland as well. I don't think that figure is going to be any different. So we had this crazy idea. What would happen if we put people with all kinds of chronic conditions all together in the same program? What would happen? And that really was a crazy idea. It was so crazy that it took us 2 years to get anybody to fund us. And then they only did it because they were sure we were going to fail, and they wanted to get us off their backs. But we did finally get somebody to fail us, yes, right. They were right. We got the federal government to fund us, and we actually used some state tobacco money as well. And what we found were outcomes very, very similar to the arthritis program. People had less symptoms, they were more physically active, they had less healthcare utilization. Based on those findings, over the last 20 years in the United States, to a great extent, the federal policy has moved away from disease-specific programs and into generic programs. And in the United States right now, the chronic disease program is being given to between 50 and 70,000 people a year, which is not very many, quite frankly, given the size of our population. But it's still a fair number. Recently, we've all had economic downturns. One of the things that happened in the United States during our economic downturn is the federal government gave out stimulus money in some kind of strange ways. I still don't quite understand why or how. But one of the ways was very beneficial to us. They gave out funding to all the states that wanted it. As it turned out, 47 of our states actually wanted it. And to see what would happen if they could get the chronic disease program to be given through what we call our aging network. Those were our senior centers. During that time, they also gave us some money to evaluate this. And this is a study, this is the biggest study that we've ever done with the chronic disease program. It is 22 sites, and by sites, I mean something like a part of a state. The actual courses were given in well over 150 different places. So 22 sites. All the training and all the leaders was actually done by the sites. We at Stanford had nothing to do with these people. The only thing we did was we collected data. So we sent out questionnaires. The first class, people filled them out. They sent them back to us at Stanford. And then after that, we collected data at 6 and 12 months. And then we took all the data and we shipped it off to the University of Texas, to Texas A&M University, to Marcia Lorig, who did the analysis. So it was a fairly complex study, but we ended up with more than 1,000 participants. So it really was a national sample, very much like the sample that you saw earlier from Ireland, which was a national sample of arthritis. Quite frankly, these are the only 2 national studies I have ever seen. So I think that's pretty impressive. And approximately 40% of these sample were underserved minorities, about 200 of them were African Americans, and about 200 of them took the program in Spanish and filled out their questionnaires in Spanish. And it focused on the triple aims of healthcare. Triple aims is jargon that is being used a lot in the United States now, but what it really means is better outcomes, better care, lower costs. That's what the triple aims are: better care, better outcomes, lower cost. So let's look at the better care. People were communicating more with their physicians. They had better medication adherence. For those of you in the healthcare industry or for those of you in pharma, the fact that we actually measured adherence, this was the first time we had measured adherence, and we had better adherence. And we had better health literacy. Health literacy just means that people were able to deal more with the health information they got in a more productive manner. We had better outcomes, better self-assessed health. Since our early studies, we've moved to actually measuring depression by a scale called the PHQ-8. I can talk about that more if anybody's interested in it, but it's a screen for depression. It's used very widely in physician practices today. They improve their depression. What's not on this slide is those people that were clinically depressed did sensationally well. People that weren't depressed, as you'd expect, they didn't move much because they weren't depressed in the first place. But the people that were actually depressed actually did very, very well. They did about as well as they do on antidepressants. People's quality of life improved. Their unhealthy physical days, they had fewer of them. Their unhealthy mental health days, they also had fewer of. So we had better outcomes. And now the cost piece of it. The cost piece of it is a bit of a complicated story. These are all 12-month outcomes. What happened was during the first 6 months, they had fewer hospital days. And at 6 and 12 months, they had less emergency department visits. And by the way, all of these data have been recently published. And the cost article is about to be published. It's not been published yet, but it will be. But I'll give you the bottom line. The bottom line is that we had about a 3% reduction in hospital costs and a 5% reduction in emergency department costs. The intervention in the United States costs about $300 US, and the calculated savings was about $400 per person. And I'm happy to say that these were done by decent health economists and not by me, who doesn't know what she's doing. So, as I said, and these will be published very quickly, I'm pretty sure. Now, will the same thing happen in Ireland? Probably. Looking at the data that we've seen here, it'd be really interesting to give those data to a good health economist and see what happens, because they do all kinds of strange things with them. And, I don't know exactly what the figures would be, but they'd be similar to this, is my guess. So, a couple of other studies you might want to know about. We did do a study where we took people with arthritis. We randomized them to either take the arthritis course or the chronic disease course. They actually all thought they were taking an arthritis self-management course, because we just called it all the same thing. The courses were held on the same day at the same time in the same building, and people were assigned to either course A or course B, and we kept them separated so they couldn't talk to each other. At 12 months, the only difference between the two courses was the people in the arthritis course reported a little bit less fatigue. At 12 months, everybody reported better self-reported health, less health distress, better role function, improved confidence or self-efficacy. So, should people be taking a disease-specific course or a more generic course? That's a policy decision every individual place has to make. I'm not here to make policy. I'm here to kind of show you the data, but at least this raises the possibility that there is more than one way to do this. So just a few conclusions, and these are conclusions drawn from studies that I've shown you, studies that I haven't shown you. One advantage and disadvantage of having a 30-year career in this is that there are studies that I've actually forgotten. To prepare this series of slides, I actually had to go back and look at data I had long not looked at. That both generic and disease-specific courses work. There are a few differences in outcomes. Workshops held in the community tend to have better attendance. People often ask us, should these be held in a clinical setting? Should they be held in a community setting? Community courses tend to have better attendance and better retention rates. And why is that? Well, number one, clinical settings are not always convenient to people. Also, hospitals and clinics are not where people most want to go. I don't know about you, but I don't love going to a healthcare setting. Why should I like to go places where people give me bad news and poke me with things? So that's, and especially when there's poor parking and you have to walk down long corridors and you get thrown out of rooms because they need them for somebody else before you think they're going to need them. I can see here that you all recognize these problems. They're not just American. So that's where we give courses in the community. Where do we give them? Public libraries, grotty church basements, community halls. I really don't care where the courses are given. One of my favorite places is in a Latino community in San Diego. They held them in somebody's garage. It seemed to work. Peer-led classes, and another question I always get is, well, wouldn't this be better if these were really all health professionally led? I know it'd be more expensive, but wouldn't they be better? We've actually looked at this a number of different ways. We have no evidence that professionally led classes are any better than peer-led classes. What tends to happen is those classes that are led by peers, people do more. Those courses that are led by health professionals, people actually know more and do less. And there's some disadvantage to health professionals because what happens is health professionals are expected to be experts, and people in the class will very often ask them questions in which they have to be experts, and then the health professional becomes the expert and doesn't end up teaching the health management skills. The peers, it's really easy to say, I don't know, why don't you go and find out? It's much harder for a health professional to say that. And I say that having taught the course as a health professional. And we really, really need physicians and other healthcare professionals to refer, but sometimes beliefs of health professionals get in the way. Beliefs those folks can never learn anyway, my folks won't go, I'm better than any course in the community. I don't know enough about those crazy people at Arthritis Ireland, and I'm not sure I really trust them with my patients. And we have a long way to go in helping with that. I will tell you that after 32 years, for the first time in January, courses will be given at Stanford. So if you think you have problems, I'm pretty excited. Somebody actually, that I didn't know at Stanford, discovered these somewhere, came to me and said, did I know anything about them? I said, yeah, a little bit. So I tell you that story because I don't want you to think it's just your problem. It's our problem as well. We talked about that. I'll just show you this. This is a study about physicians' beliefs. And this is the results of that study. That physicians and other clinicians strongly thought that patients should follow medical advice. They were less likely to think that patients were able to make independent judgments or take independent actions. They thought they weren't really sure that patients should function as a member of the healthcare team. I don't know, are you talking about healthcare teams here? Yeah? My favorite expression now comes from football. And it's the patient should stop being the ball and start being a member of the team. And the least endorsed notion was that patients should be independent information seekers, which to me is kind of astounding because in today's internet world, everybody is an independent information seeker. How many of you in this audience have ever looked on the internet for any health information? Yeah, sure. Yeah. And that's the whole point. That's the whole point. All right. So that's a very brief story. Do we have time for questions or not?
Yes,
Yeah.
we do. I was going to
maybe for everybody.
I was going to suggest that we actually do have one or two questions because to break things up. We're slightly behind time, but you know they're not going to throw us out of it. So does anybody have? We're going to take probably two or three questions for Kate, and then we'll go on to Pat, and then we'll have a panel discussion at the end of it.
Okay.
So you will have an opportunity to pose a question if you're too shy to do it now. Can you please just wait for the mic first, and then.
And I also promise that I'm not going to go away until I answer everybody's question. I don't mean right now, but I mean at the end of this. If you have more questions, I'll stick around. Yes?
Hi, I'm just wondering from your own perspective, the reason physicians is a barrier to them being, kind of referring on to that management. Mm-hmm. Just from the American perspective.
Yeah, I think that the biggest barrier is, quite frankly, today, that they don't quite know what it is. There's an awful lot of foolishness, silliness, dangerous stuff out in the world trying to sell things to patients. And trying to separate this out, what we're doing out from that is very, very difficult. So I think a lot of it is that they don't quite know what it is. The other thing that I think is very important is they don't quite know how to refer. Because what happens is they don't know where courses are, when courses are. We're doing a lot of work in the United States now, especially at the local level, to say there will be a course starting the first Monday of every month at. So it's a consistent message to physicians. We're doing a lot of work with websites so that people can look up where courses are. So I think those are the two biggest barriers. It's not because they're mean, nasty, awful, old-fashioned. It's none of those things. It's just that we're a very strange animal. And people are very suspicious of strange animals. And our job is to become a little less strange.
Hi, thank you very much. It's really very interesting to hear you speak, having read your work for so many years. Can I just ask you your opinion on the need for top-up sessions?
How about top-up sessions is the story. We have done now 3 studies with top-up sessions. They've been different. I'm not going to go into the details. If somebody wants them, I can point you to them. In none of these cases has top-up sessions made one whit of difference. Now, 2 things may be going on. One is that I have no idea how to do top-up sessions, which is quite possible. The second is that while we have a very strong belief in reinforcement or in top-up sessions, the literature on the topic is actually pretty weak. And it's kind of my feeling that once you teach people self-management skills, and once they see the benefit of them, because they're doing them for themselves, not for somebody else, they really don't need top-up sessions. And my example for you is this. When was the last time anybody told you to brush your teeth? And how many of you brushed your teeth this morning? My guess is most of you. And my guess is for most of you it's been a very, very long time. Why do you brush your teeth, which is a self-management skill? Because it's personally rewarding, and not doing it is personally punishing. And so I use that as kind of the example. The question's really out on top-up skills, and I'm not saying that we shouldn't do it. I'm saying that I probably won't do it again because I've been unsuccessful 3 times, and 3 failures and you're out. So, taking a US baseball term.
Okay, we've probably time for one more question. Anybody over here? Keep it balanced.
Hi, thank you very much for a very interesting presentation as always. I would be particularly interested, Kate, to hear your feelings on how chronic disease self-management sits with other forms of rehabilitation and education of patients, such as cardiac rehabilitation, pulmonary rehabilitation, and those kinds of things.
Yeah, how does chronic disease sit with other types of rehabilitation? Most other types of rehabilitation are aimed at a very specific thing during a very acute phase of disease. And I don't see the 2 things as being at all in conflict. Because what self-management is okay, you've been to hospital, now you've kind of gotten through the acute phase of the community part of your disease, now you've got to learn the skills to lead the rest of your life. And so I actually see them as being complementary. The other piece is that unfortunately, most people, at least in my country, do not have an opportunity to do any of the intense rehabilitation, such as cardiac rehab, pulmonary rehab, etc. It's too expensive, it's just not available. It's too far away from them. And I don't think that self-management is a replacement for that, but I think that it's probably the best we can do on a public health national basis. And I think looking at that more bears some looking at.
Okay, we're going to get a little bit of time later on
Okay.
in the panel discussion.
Thank you.